Welcome back to Doc Talk. We did foot problems earlier today, and now we're gonna address some neurological issues. I want to welcome Dr. Harrison Walker. Harrison, thanks for coming.
You're welcome. Thank you very much for the invitation.
I pigeonholed him. We play ultimate frisbee together, and he's like, "Are we going to go to the office to do this?" And I'm like, "No. We're doing this out here." So we just finished ultimate frisbee. We won.
We did.
Yeah, we don't usually win, so we can celebrate that. Harrison is a neurologist at the University of Alabama at Birmingham, UAB. And he specializes in, I believe, movement disorders. Is that right?
That's right.
So tell our audience, whatever that is, what is a movement disorder specialist?
Well, first of all, thank you very much for the invitation. I'm delighted to be here. Movement disorders are problems typically from the central nervous system that
the brain,
as the name suggests, that cause problems with movement. So the most common symptoms of movement disorders are tremor, an involuntary shaking movement. Another common movement disorder is Parkinsonism. So there's rest tremor with Parkinson's, but also slowness of movement and muscle stiffness or rigidity. And there are various other movement disorders. Those are the two most common.
Parkinson's would be one of the more common things.
The two most common movement disorders are Parkinson's disease and essential tremor.
So at what age in life does one would one start to notice Parkinson's?
So the age of onset of Parkinson's disease varies very substantially, but the average typical age of onset is age 62. It's a little more common in men than it is in women. That being said, there are familiar cases of people with much younger onset of Parkinson's disease. And there's a lot of variety. One person with Parkinson's is not like another. The disease varies a whole lot from one person to the next.
So my dad had Parkinson's disease, so very familiar with the symptoms. But I grew up in Michigan, and obviously we live in Alabama. Is there some connection between where you live in the country and the disease? Is there any geographic?
Not that it's known.
Okay.
Now there have been some epidemiological studies that have suggested that rural living might be associated with Parkinson's. And the cause of Parkinson's disease is not known. It can run in families, so maybe 1 out of 10 cases of Parkinson's there is a hint of a familial component or a strong family component, but most people with Parkinson's have the disease without other affected relatives. So in the majority of cases of Parkinson's, the cause is not entirely clear.
So we don't really know what causes the disease. Do we speculate it's a virus of some sort?
There are lots of different ideas about, so first of all of the genes that are mutated that we know are associated strongly with familial forms of Parkinson's. There are protein pathways in the mitochondria and in other parts of the cell. That's the power plant of the cell that gives the cell energy. There are theories about inflammation in Parkinson's. It could be almost like an autoimmune disease maybe that makes the progression. But the bottom line is that in patients with Parkinson's disease, there are nerves in the brain that make something called dopamine. And dopamine is very important for movement. So it makes our movements more fluid. And in the absence of dopamine, there's shaking, there's slowness of movement. And so for some reason in patients with Parkinson's, these nerves that make dopamine in a part of the brain called the midbrain or the basal ganglia, it's like they age faster than the rest of the body does.
Yeah, I liken Parkinson's disease and Alzheimer's actually to arthritis of the brain. You know, some people get it in their hip, some people get it in their knee, some people get it in their brain.
Well, that's actually a real contemporary current in terms of thinking about pathogenesis of Parkinson's, and that's actually a relatively new, the idea of inflammation in Parkinson's is a newer idea. There have been a lot of theories about Parkinson's, and a lot of theories that really haven't held a lot of water. There's a lot of work that it still needs to be done, and at UAB we're working every day to try to find better treatments and hopefully a cause for Parkinson's.
Yeah, and certainly inflammation is a big characteristic of arthritis, but really what I was also hinting at is that it's some people age in their joints such that they need a hip replacement, but some people age in their brain such that they need a brain transplant. And so that begs the question about stem cells and any way of causing these tissues in the midbrain that make dopamine. Where are we at with that type of very new age, modern?
Well, there have been some attempts at stem cell therapies for Parkinson's disease, and there have also been attempts at using injecting genes into cells, into dopaminergic cells with viruses.
Right.
And so there's still interest in these topics, but the early studies on these have not shown definitive improvement. And so there have been a lot of efforts, but these are small studies. They're very difficult to do. They're challenging from the regulatory standpoint.
Where do you inject the cells? Would you put them in the spinal fluid? Or
there have been injections in the striatum. There have been injections
directly into the brain.
Into the brain. It's primarily into the brain. So into the striatum, into the area, the substantia nigra, which is the dopamine area.
Now I know you have a focus in deep brain stimulation, right? Isn't that like a pacemaker of the brain?
Yeah, so really in Parkinson's disease, in my view, the two revolutions in therapy in Parkinson's disease, the first one is levodopa, or Sinemet, invented in 1967, and one of the Nobel Prize winners for the discovery of the dopaminergic system actually recently died. That was in the news, but that was a really seminal finding and led to the Sinemet, which is still, since 1967, probably the best medicine that we have. Probably the second biggest therapeutic advance has been brain stimulation. And deep brain stimulation is very, very effective, remarkably effective for tremor and slowness and muscle rigidity associated with Parkinson's. And really, I think importantly, it works when medicines are not working well anymore, when medicines become unreliable, which is sort of a characteristic of more advanced Parkinson's, where in early Parkinson's, just the tiniest little crumb of levodopa or Sinemet can make someone seem almost totally normal. But then as the disease progresses, every day becomes more like a roller coaster, where the medicines kick in and then they wear off and kick in, and there are involuntary movements, and then there's tremor in between when the medicine's off. So the brain stimulator sort of smooths that out. It's like a light bulb.
How?
There are a lot of ideas about how brain stimulation works. Certainly brain stimulation originally arose from making tiny focal strokes, actually, lesions in the brain. And you could still make a radiation pallidotomy.
That's
or
what Michael J. Fox had, right?
He had a traditional thalamotomy. Now, I'm not his physician, so I don't know.
Okay.
I may not know all the details of his case, but he had a traditional radioablation, I believe,
where
thalamotomy.
they destroyed some of the brain tissue.
Yes. And so the thalamus is a very good brain target for tremor. The subthalamic nucleus and the globus pallidus help tremor, but they also help rigidity and slowness of movement. And the globus pallidus interna and subthalamic nucleus both have this characteristic of blocking the dyskinesias. So there are a number of targets, and they all have a little bit different properties.
But we don't know how so how did we discover it? Who came up with the idea, oh, let's just put some electricity in there?
It's a great question. So one of the
Before you get started, I almost lied to you ever said the light is not on you, man.
Okay,
Sorry.
that's all right. That's all good.
Okay.
Any questions,
Perfect.
by the way, or people? Nope. Okay.
I'm going to let you finish. And actually, my grandfather had Parkinson, so I've got some questions, but I'm going to let you finish.
Well, the question of how this was stumbled upon, it's been known in the field of stroke that there would be an elderly patient with tremor, and the patient would have a hemiparetic stroke, recover from the hemiparesis, and then the tremor didn't come back.
Okay.
And so that was a clue. So these patients were looked at very carefully. There were autopsy series. Where was the stroke in this individual? So then eventually the idea was, well, maybe we could go in and actually tie off the small artery that goes into this part of the brain, and it worked. So that was a very invasive way to go about this. And this is way back, probably
Sure.
the early or mid 20th century. I don't know the exact date.
Okay.
And the problem with that, as you might imagine, is that in some of those patients it actually caused a stroke because
Sure.
because the vasculature,
Well,
the
that's
blood
what
vessels.
you were trying to do, is cause a stroke.
It just depends on the extent of it and where
Right.
it occurred, and so that was unreliable. So then, basically, you could put a probe down into that part of the brain that was identified in the series, and then essentially just burn a hole in the brain focally, in the brain tissue, rather than
Sure.
blocking a blood vessel.
Right.
So that's how it started. So then people would use these radio frequency probes actually to tell you where you are in the brain.
Hey, got it.
So
I
you
got
could
it.
so you could turn it on, and if you were not in the correct location, it would draw the mouth up like this,
Right.
and then they'd say move it medial, and you'd move it
so
away
when
from
they
that.
were doing the stimulation to make the lesions, they noticed that the stimulation actually.
And then if it was in the right place, it actually helped the symptoms.
Interesting.
So then there was this so the problem with the lesion is it's point and fire. So you basically,
Sure.
you just got what you got. You
Right.
can map all you want to, but eventually you're going to make a hole in the brain. You can't take it back.
Right.
And so eventually the companies started making brain stimulators, and the advantage of the brain stimulator, it's a very tiny wire that's sort of pushed down into this part of the brain, and the electrical field is adjustable. So you can turn it up and turn it down. And so that's a big advantage, to be able to adjust and move the area of the stimulus
Sure.
to different locations in that small focused region inside the brain.
Blake, did you have
Yeah.
a question?
So I want to go back. You were talking about you're not sure exactly what causes Parkinson's or whatnot.
Mhm.
Your dad had Parkinson's. My grandfather had Parkinson's. What are the risks of he and I getting Parkinson's?
That's a very good question. So so about 1 out of 100 people over the age of 62 have Parkinson's disease. If you have a direct blood relative with Parkinson's, like mom or dad, you do have a more elevated risk of Parkinson's, but it's the absolute increase in risk is very small. So I don't know the exact numbers, but it would be on the order of 2 out of 100, 2.5, 3 out of 100. It's still very, very unlikely.
Very small, but
But
still
it
doubles
does-
or triples your risk
it does-
relative to the.
It does impact your risk in a measurable way. But about the brain stimulation, so there's this analogy that we have with making a hole in the brain. I mean, there's some obvious parallels because the lesions have similar clinical effects, very similar clinical effects to the brain stimulation. But whether high frequency brain stimulation deep in the brain is inhibiting the nerves in that area, or jamming the signals. There are people like me who are academicians sort of parse their words very, very carefully about, is it jamming, is it replacing, is it activating?
Right.
There are lots of different, and it's a very, very complex network.
When you say high frequency, my ears turned up because in the pain world,
Mhm.
we've gone from low frequency
Mm.
to extremely high frequency.
Yeah, kilohertz, right?
Yeah, yes, to sub-threshold where you can't feel it, but the frequency is quite high.
Yes, interesting.
So I'm curious what you meant by high frequency.
Well, so the frequencies that we deal with brain stimulation are I believe, lower than the frequencies than in the spinal cord stimulation world. And with great interest, I've learned about some of the more recent, very high frequency spinal cord stimulation just from being at meetings and
Sure.
being involved in neuromodulation more broadly. But our frequencies, so for tremor, to suppress tremor, you really have to get above 100 hertz,
Okay.
90 hertz.
It's not that high for us.
Not for you guys.
No.
No, not at all. But it is a mystery of brain stimulation. 20 hertz stimulation does not improve tremor. 40 doesn't, 60 doesn't. But you do reach this critical range around 90 to 110 hertz where tremor will noticeably be suppressed.
What are the side effects?
Great question. So with respect to brain stimulation, obviously if you turn it up high enough, there can be side effects. You can affect commonly the speech, but with the brain stimulator, you can turn it up, you can turn it down to avoid side effects if they occur from stimulation itself. So I'm the co-director of the brain stimulation program at UAB with our neurosurgeon Bart Guthrie, And Bart's team makes a tiny little burr hole about as big as your thumb on end. You pass that lead down into the part of the brain that is involved in these movements, and by virtue of passing the lead through, there's about a 1 in 100 chance that you could have oozing of blood around the lead, and it could, in some instances, cause the symptoms of a stroke. So there's probably a symptomatic stroke in about 1 out of 100 cases. So 99 out of 100 don't have it, but this is the reason that everyone with Parkinson's doesn't have a brain stimulator.
Is because of that small risk of stroke.
Just the small
How
risk
bad
of
is the stroke? Is this a brainstem stroke? Is this
It can range from being very, very, even completely asymptomatic to being a severe stroke. Not typically a brainstem stroke. It typically would involve some hand weakness, slurred speech.
So I don't know if this is myth or true or not, but when my dad actually had a deep brain stimulator, they cautioned him about personality change. Is that
people have talked about that, and I think that is more myth than reality. I mean, that's not something we see very often.
Okay.
This is a motor therapy. In fact, in Parkinson's patients, sometimes they're on very high doses of medicines that give them a lot of behavioral symptoms, and bringing those medicines back a little bit can often make people more themselves.
Okay.
Just the ability to reduce the medicines. So it's a complicated question, because these are the patients with the most advanced Parkinson's disease, and part of what goes with that is cognitive and behavioral disturbances. So, whether the brain stimulator is actually causing that, I think, is, in someone with very advanced Parkinson's, could often be questioned, especially if it's something that happens years after the intervention.
And since we're out here on a nice night, ultimate frisbee, tell them about exercise and Parkinson's.
Well, I tell every patient I see to be in a regular exercise and stretching program. I think that it is very beneficial for general health. Patients with Parkinson's, we know from studies on Tai Chi and physical therapy studies, patients with Parkinson's can learn about their limitations. And one of the ways to do that is to be sensible, but to be active. And so I think it's very beneficial. There's a general feeling in the field that people who exercise with this disease do better.
A friend of mine was telling me that they thought dancing was good for Parkinson's.
They love it. So their patients in Parkinson's, they find things, and I do think that most of the evidence that's out there does suggest that it's not specifically what you do that's important. Dancing would be good. There's a lot of people, you probably have some patients who tell you about the boxing program.
Yes.
That they do for Parkinson's. They love it. They love it.
Yes.
So that maybe you like resistance training. Maybe
so
you
instead
like
of dancing your way through life, you should just box your way through life.
And then of course Tai Chi, which I ought to go do Tai Chi as often as I tell people to do it, but my understanding is that it is a discipline that is involved specifically in balance and learning limits.
So Tai Chi is sort of a physical medicine type thing, and they looked at falls in the elderly. And what they did is they looked at a very, very computer, high-tech, where's your center of gravity, and compared that to Tai Chi, where they taught people where their center of gravity is, and they could see it on the monitor. And the people who did Tai Chi had far less falls than people who did computerized balance training. And the reason is Tai Chi actually stresses your center of gravity. It lets you know your limitations as to how far you can go. You know what I'm saying? So
we're actually doing some studies now with brain stimulation, collaborating with Chris Hurt over in the physical therapy group, and they have these large machines with harnesses. It's totally safe, but they can actually test the limits of postural stability. So you could turn the device on and off and look and see how specifically.
So it's sort of a computerized way of teaching Tai Chi.
Yeah, well, this is in the context of an intervention and a research study, seeing how that postural stability limit might be altered, or what we could do potentially to alter it with therapy. So that's really an important topic in advanced Parkinson's.
Why don't we throw a little bit and then we'll call it? Anybody?
I have a quick question.
Okay.
One more. So another popular neurological disease that's out there, especially athletes know about, is ALS or Lou Gehrig's. What I think a lot of people get those two confused. What is the major difference in ALS and Parkinson's?
Well, that's a great question. So I had mentioned that in Parkinson's, the dopamine nerves in the substantia nigra.
That's in the brain.
That's in the brain. Those are the cells that seem to age faster than the rest of the body. In ALS, it's the motor nerves. So the motor nerves that leave the spinal cord and go out into the muscles and give the muscle command to move, and also nerves that are farther up in the brain. Now, all of these neurodegenerative diseases are, they have a kind of attraction to a specific part of the brain initially, but over time, it spreads.
We gotta go. We gotta
elsewhere.
go. Let's walk and talk.
All right.
Can we walk
we'll
and
do
talk? Let's walk and talk.
This is true live. This is true live TV right here.
Live. This is as live as it gets.
Live as it gets. Are we recording?
We are. We're gonna keep it going.
We had to ask that one more question.
Yeah, I tell you.
Basically, with Lou Gehrig's and Parkinson's disease, that degeneration process, for some reason that's not real clear, there's a different attraction for different types of cells in the body.
I got that.
So in Lou Gehrig's disease, there's a lot of weakness and muscle stiffness, trouble with speech and swallowing. The primary source of neurodegeneration in Parkinson's is higher up in the brain, in the basal ganglia. There's degeneration in some higher motor circuits in ALS as well, but they just affect
So ALS is more affecting the motor neurons, which means they're going to be weak.
Right.
Whereas Parkinson's is affecting cells in the brain that sort of organize movement.
Right.
Which
so
means the movement's going to be disordered. They're not going to be
Right.
weak, they're going to be disordered.
So the movement's more incoordinated, disorganized. There's more of a tendency towards involuntary movements, whereas in ALS, it is the big problem is weakness.
Whoa!
That's a great way to stop. All right, we'll call it there.
Anytime you want me to do it, I'm happy to do it.
Thank you so much. Wait. Are you still rolling?
We're still rolling.
Okay,
I
good.
see some.
I think you invited us into the OR, right, to see a deep brain
Absolutely.
stimulation.
We'll get it set up.
So we have to work on that.
Yeah, we'll
All right.
have to go through the steps, but we'll get it done.
All right. Thanks, Harrison.
Hey, my pleasure.
I
Enjoy
appreciate it.
You guys have a great evening.
All right, bye.
All right.
Oh, I can see you now.
That was fun. Thank you.
It was fun, wasn't it?
Yeah.